So mine is not going to be rocket science. We heard two great lectures on osteotomy and all that. I was asked to speak on knee injections. Uh, Obviously, the injections are becoming too popular these days for various reasons. When I see a patient in my clinic, I show this slide to almost all of my patients. On top, you see the KL grading of the knee problems, starting from grade 1 to grade 4 on your extreme right. And below, there is a spectrum. This is there in my clinic, and most of my patients will get to understand this spectrum. What it means is here, if you are in an early stage of, for example, knee OA, we start with our regular medications, alternative medicine sometimes, and we start with physiotherapy. And as things progress, there is one area where we also think about injections before we go into big invasive procedures. And when you talk about injections, obviously all of us know this, but just for completion, I've added two more options. That is a Nozon, which I came across doing literature search, and stromal vascular fraction. Again, I don't have any heavy pictures here to show, but I thought what I'll do is I'll look at the evidence, which is more important. And we all know, about 15, 20 years ago, when we were talking about steroids, and there used to be litigation issues, especially in osteoarthritis. Things have changed over a period of time. Now, this is obviously, there is so much evidence, as you can see, that one of the most favorite options for especially grade 4, and it's been happening everywhere. Now, if you look at ortho evidence, the biggest orthopedic resource on evidence-based medicine, you will see a lot of articles on steroids, and Mohit has done so much work on this. And this is one of those things which I wanted to share with you, because I think when patients come to see us, the obvious question that you face from patients is it steroid? And moment you say it's steroid, they're not somehow happy to take it, but they're okay to take painkillers. And then when you talk to them about both options and the side effects, and some people agree. But I think this is one of those papers which I also share with my patients. Now, what usually happens when someone is in severe pain, I think this is the best option, in my opinion, and I do a lot of them. Now, if you are looking at this option, let's just talk about steroid at this point. The first 1 to 4 weeks, it's very good for the patients. And effect of these injections appear to diminish afterwards. Maybe this is something that we should say. I tell my patients that you are probably okay for the first 3 months. If it works for longer time, you're lucky. If it doesn't work for a longer time, it's not my fault. So I think that's how I go about it. And there was this paper that I came across, again from one of the papers in 2017 from JAMA, that whether this is something that we should be worrying about. But if you really ask me, stage 4 or grade 4 osteoarthritis, there's hardly any cartilage there. So maybe this is something that's irrelevant for that group of patients. This article, I'm sure you would have heard in or read in Ortho Evidence way back in 2020, one of my favorite articles. And there are people who believe in steroids, and they always say they work really well, it is safe, and nobody has ever said that they're worse than physio. That's me. Okay, there are some people who always say, okay, it's not good, they don't work. And so it depends on what you believe in. And then people say they may damage your cartilage. But my argument is, if it's a grade 4 osteoarthritis, what damage you can do. And physiotherapy is better. That's what some people say. The next injection option, I think this has actually created waves in the last 2 decades, hyaluronic acid. Now, my purpose of my lecture here is to actually highlight on the use and why we are using it. Okay, and what is the best solution for us to use in our clinical practice. So what does hyaluronic acid do? It works by replacing or supplementing hyaluronic acid in the diseased knee joint. It is supposed to restore lubrication and stop absorbing function of the synovial fluid. Now, when you're talking about hyaluronic acid, I think this is probably one of the most important issues. So you need to have something, in the market you have, now there are 10 different types of viscosupplementation products, but I think we need to have something that has more than 3 million Dalton's molecular weight. And this is published in a paper in 2017, which is very important. Then comes the next option where should I actually doing the steroid or should I be doing the hyaluronic acid? Patient selection is very, very important. This is where we come in as clever surgeons if you decide to do the injection. Now, on the long run, hyaluronic acid provides longer pain relief, and there is strong evidence. The papers that I've actually shown in my slides are all powerful papers, level 1 papers, and I've picked up most of them from ortho evidence. So yes, hyaluronic acid, I think if you're looking at stage maybe 2 or 3, it's probably the best option. And they give prolonged relief compared to corticosteroids. But having said that, we have to also remember there are some clinical trials that have shown potential adverse effects with hyaluronic acid. I have had a personal experience with a VIP. I did viscosupplementation injection. Evening joint was swollen, and I had to rush to their house. And in my entire 20 years practice, I've seen one case. Now, again, there is more evidence and the evidence, steroid treatment of knee longer lasting pain relief and functional improvement with hyaluronic acid, highlighting that on the long run, hyaluronic acid is probably going to be your option for knee OA. We have to be also be prepared about the preparation. So predictors for failure in hyaluronic acid or viscosupplementation, those who are obese and those who are in grade 4 or beyond 4, and if there is patellofemoral involvement, some of those contraindications, especially if you're planning to use hyaluronic acid in your patient. If there's a major malalignment, that is another contraindication. So I have no experience with ozone, but I found this paper, level 1 evidence comparing platelet-rich plasma. We are now moving on to the next level, hyaluronic acid and ozone. And the paper says that both PRP and hyaluronic acid show superior efficacy compared to ozone injections. I don't have any experience, but I've had a lot of patients coming back to me and asking about ozone injections. So I don't know how it works, but on the long term, now we have 2 very useful options for knee arthritis or knee problems, that are PRP and hyaluronic acid. I'm going to concentrate now a little bit on the PRP. So this is another paper which was published some 5 years ago, very, very important paper showing that both PRP and HA injections improve pain and function. Now, if you're in that stage, which is good for your patient now? What are you thinking about? Should you be looking at PRP? Because now that you have good evidence on the use or long-term relief with the use of hyaluronic acid. So we will be looking at now PRP, what's happening with PRP. Now, intra-articular PRP is significantly better than hyaluronic acid. And this was 2 years ago. Again, level 1 evidence. In fact, in the last 4 or 5 years, we are seeing increasing number of publications on the use of PRP in early OA. So this is one of those RCTs, and which was published in 2017 with the use of PRP with variable protocols. Now, when you look at PRP, this is beyond the scope of this lecture. There are issues about preparations and so many things about PRP solutions. And this particular paper showed that PRP is safe and effective, and it's much, much more responsive in younger patients. This is a busy slide. Now, I mentioned about the preparation of PRP, which is, I think, very, very relevant to our clinical practice nowadays. Now, I just want you to concentrate on the column which shows type of PRP, which is 1, 2, 3, 4, 5, 6, 7th column. You have leukocyte rich PRP, you have the solution that is not recorded, and then you have leukocyte poor PRP. The last two rows, you see leukocyte poor PRP. Now, if you see the favors, now in the OA, it has always been the LP, that is leukocyte poor PRP, that has been more useful than leukocyte rich PRP. There is a very strong message in this slide saying that if you are ever planning to use a type of PRP for your knee OA patients, it is better to use leukocyte poor PRP. Now, this was again my favorite paper from Author Evidence, and what the authors did was they compared PRP to placebo, non-operative treatment, steroid, hyaluronic acid, and surgery alone. And on your right, the column number of trials, you had large number of trials comparing PRP to hyaluronic acid. And when you're looking at placebo, PRP did well. When you're looking at non-operative treatment, PRP did well. When you are looking at steroid, obviously, that was 3 months follow-up. And with hyaluronic acid, PRP did well. About 2 years ago, there was another major paper that appeared in American Journal of Sports Medicine with comparing again PRP with hyaluronic acid. And they looked at 18 level 1 studies comparing PRP with viscosupplementation, because there was so much debate around this 2-3 years ago. And mean follow-up in this paper was 11 months, less than 1 year. And PRP group did significantly better looking at these outcome scores. Look at WAS, WOMAC, and IKDC. And see the last row, leukocyte poor PRP did performed better than the rich one. So looking at the PRP option in this entire exercise, see safety, it is safe, efficacy, it's safe, evidence, it's good evidence coming out now, and cost-wise, also it's equally, it's as good as hyaluronic acid. Now, there's one more slide I wanted to actually add, that I was just doing some research this afternoon, and now PRP is taken as an injection option in the UK. The nice recommendation is that you have to use careful assessment of the patient with informed consent and use leukocyte poor PRP for osteoarthritis. I thank you for your attention. And